Next, we have Dr. Mary Regina Boland, an assistant professor of informatics at the University of Pennsylvania. She is a leading informatics researcher in the field of prenatal and perinatal exposures and has studied the effects of birth seasonality on later risk of disease in several populations, including the Americas and Asia, where she presented as a lightning talk at last year's symposium. Dr. Boland has also confirmed some of her findings in humans in a canine population. She is currently expanding her work into European populations and is looking for more OHDSI collaborators interested in her work.
Thank you, Melanie, and thank you all for being here to listen to my work. So first, I wanted to start with a question, and this question, which I think many of you may know the answer to here as clinicians and terminology experts. You may know this answer to this question. So what do these two things have in common? This would be a motorcycle accident and a pregnancy. Does anybody know? Possibly? Perhaps? Okay, so these are actually both V23 codes in ICD-9 terminologies, and the only difference is the version. And you can detect this actually by, if you don't know this, you can detect this by seeing a dramatic shift in your gender population over years, as women are commonly diagnosed with pregnancy and males are commonly diagnosed with motorcycle accidents, which I found very interesting. This always made me laugh, actually. So this actually highlights the importance of linking terminologies to standard structures that can then be mapped across multiple different terminologies, not just different terminologies, but different versions of terminologies. So as a member of OHDSI, they have used the SNOMED CT, which is the systemized nomenclature of medicine, and also expanded upon that to map all of the different codes in different terminologies to this standard architecture. So this is just a schematic of how different codes in different terminologies can be linked to different SNOMED concepts. And SNOMED concepts are actually organized into hierarchies, so then you can leverage those hierarchies, which I'm going to talk about in a few minutes. But this became important as part of my birth season project, because initially we started out, and this is the map here, the purple diamonds showing the different sites that we had originally. And when we tried to add data from the Netherlands, which is a collaboration with Peter Regina and those at Erasmus Medical Center, this kind of highlighted some of these interesting issues with the terminology mapping. So the first part is that when you have, and this, I'm sorry, this got garbled, so this must be some issue with the Mac to PC thing. So this worked on Melanie's laptop and we checked, but unfortunately, it's a PC here. But this issue is the first column with there's about 354 condition concepts that were common in the US sites that were part of this study. So this included Vanderbilt University, University of Washington, New York City. We had Columbia University as well as Mount Sinai data. And there were 354 condition concept IDs that were common across these sites. And these are, we restricted it to have at least 1,000 patients per condition concept. So there are some prevalence constraints as well here. But when we started to add the 2 Asian sites as well as the site from Netherlands, if we add all 6, or 7 actually, I think, sites, we end up with only 701 condition concept IDs that are in exact, complete agreement, whereas the exact same concept ID in all sites. So what we did was we then started to look at, so we have a total of 4,340 condition concept IDs that are unique if you were to pool all of this data together. And then we were able to, using the condition concept maps, we're going to focus a little bit on the Netherlands data set. So there were 249 unique Netherlands condition concept IDs, I should say, that were unique in their set, which means that they were not found in the other sites. So the first thing we did was we used this concept hierarchy to map them to other concepts that were found at other sites that were close within the hierarchy. So this is the concept map, kind of from SNOMED. The big numbers on the far left-hand side, so 0, 1, 2, 3, 4, 5, are the different levels in the concept. So 0 being kind of the top level, and then 5 being a lower level, so a more granular concept. So what ended up happening was Rotterdam, which is in the Netherlands, mapped things to the congenital anomaly of the cardiovascular system, whereas Nashville, New York City, Seattle, and as well as the Taipei group, mapped to congenital heart disease. And these are actually 2 levels apart in the hierarchy, which is very interesting. And just without knowing that this is the hierarchy, I would have thought congenital heart disease is more of a vague term than, say, congenital anomaly of cardiovascular system, so I probably would have organized it the other way. But you have to remember that this isn't necessarily semantics or other types of things. This is kind of just the hierarchy, how someone designed it initially when they designed SNOMED. They put these different levels here. So that's another important thing. And what we can do is we can actually roll up or move up the hierarchy and kind of map things to kind of more general concepts if we need to. And another interesting example is this genuine stress incontinence. In the US, there seemed to be a lot of this like kind of gender focus where they had female stress incontinence, whereas at Rotterdam they used a mixture of genuine stress incontinence as well as mixed urinary incontinence, and there was no I guess if you wanted female stress incontinence, you'd probably combine a stress incontinence code plus the gender code, but they didn't actually explicitly say this is female stress incontinence, which happened in some of these other sites. So I show this graph because most of the concepts could actually be mapped. If you mapped 2 levels of separation away, you could then actually map quite a lot of concepts. So what does that mean? So coming back to the congenital anomaly example, that would mean mapping everything that's at the 2 levels lower, so which would be like congenital heart disease up to congenital anomaly of cardiovascular system. And you can do this, and this is kind of the approach that we're sort of looking at taking. However, I do kind of want to caution people, and I think this is also important, that a lot of these inconsistencies still kind of do have to be manually reviewed, and this is a little bit of an unfortunate part of this process, but because some of the semantics within the hierarchy are a little bit vague, and you do have to kind of dig into why was this originally mapped to this concept at a particular source terminology, this is an important caveat of these data. I do want to thank the data sets originally, as well as my collaborators on this work, Heinrich and Peter, and thank you very much.